Hello, my name is Heather King, and I'm a pain psychologist at Stanford University. I'm going to be presenting on the role of pain psychology. I have no relevant disclosures, and I will not be discussing off-label use of medication in this presentation. Today's learning objectives include the description of chronic pain, identifying risk factors for the development of chronic pain, explaining the role of pain psychology, and to describe evidence-based behavioral treatments and appropriate referrals for chronic pain. According for the Centers for Disease Control and Prevention, it is estimated that 80% of all medical visits are related to pain. So if you work on the front lines of medical care, you will likely encounter these patients. Although chronic pain is so common, the understanding and resources to treat chronic pain remains quite limited. To effectively treat pain, we first start with understanding what pain actually is. The International Association for the Study of Pain updated this definition this year to include or resembling that associated with. So the actual definition is pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The resembling that associated with addition validates that one can experience pain even in the absence of tissue damage. This really helps to conceptualize pain as more than just a sensory experience and highlights the impact that cognitions and emotions have on one's experience of pain. In contrast to acute pain, where there is tissue damage and the focus is on healing, chronic pain simply persists beyond the expected recovery period. Pain that usually serves as an alarm that something is wrong with chronic pain becomes somewhat faulty with chronic pain and serves as a false alarm or a faulty signal. Therefore, it is not an accurate indicator of tissue damage. Chronic pain is often treated through this biopsychosocial approach, which takes into account all aspects of one's unique experience. The biopsychosocial model is the recommended treatment approach for all chronic diseases, and it focuses on these individual difference variables that contribute to one's unique experience. We know that it's this dynamic interaction between biological, psychological, and social factors that determine one's understanding, response to, and the impact that the pain has on their life. Psychological factors include the context in which one experiences pain, thoughts, attention, motivations, emotions, memory, and relationships. Treating pain from a purely biomedical approach simply ignores the other parts of this model, and research suggests that these other areas are extremely important when conceptualizing and treating chronic pain. Unfortunately, many people experiencing chronic pain only receive a biomedical approach. This ultimately leaves key aspects of pain undertreated. It can be devastating for the person with chronic pain as they don't understand why they're not getting better. And it can be equally frustrating for the provider who just genuinely wants to help them get better. Patients that adopt a passive role in treatment, meaning they become overly dependent on medications, interventional procedures, and their doctors, tend to be refractory to treatment, while taking an active approach can help improve outcomes. Providing this message at the onset of treatment can help improve their trajectory. As you will hear in the physical therapy lecture, nociception is a signal from the periphery, while pain is an experience in the brain. This slide was adopted from Martucci and Mackey in Anesthesiology 2018, and it beautifully highlights the areas of the brain involved in the experience of pain. These cognitive and emotional components, such as our thoughts, beliefs, attention, motivation, and memories, directly impact the pain we feel. We know that you don't have a single pain center in the brain, and that it's multiple parts of the brain that contribute to the experience of pain. Studies reveal that activity in these afferent pain pathways are altered by attention state, distraction, positive and negative emotions, placebo, and empathy. So the important takeaway of this is that our mindset, how we think and what we believe, our expectations, our thoughts, can actually turn the volume up or down on the pain experience. Providing this education helps lay the foundation for patients who are experiencing chronic pain on the role of pain psychology and the biopsychosocial treatment model. As a pain psychologist, I focus on helping patients change these unhelpful thoughts and beliefs and behaviors that are associated with their experience of pain and their overall level of function. This slide highlights all the factors, or many of the factors, that the brain takes into account when making its best guesstimate of pain. Part of my role is to conduct a thorough evaluation to identify risk factors and targets of treatment for each patient. We know that pain is not always a danger signal from the body. It's an opinion. It's the brain's opinion of what's going on in the body. These arrows show the multitude of factors used for this guesstimate of pain. The good news is that many of these arrows are modifiable. Therefore, they become the targets of treatment. There are various risk factors associated with the development and perpetuation of the experience of chronic pain. These include trauma, mental health disorders, and psychological distress. There's emerging understanding between the links of adverse childhood experiences, also called ACEs, and negative health effects later in life, including the development of chronic pain. ACEs are defined as significant negative conditions or experiences in childhood, so in persons of 18 years of age or less. And they include emotional, physical, and sexual abuse, emotional and physical neglect, and various household challenges such as domestic violence, parental substance use, parental mental illness, parental discord, criminal behavior, or incarceration. Studies have shown a dose-response relationship between ACEs and later life development of chronic pain, including a 2 to 3-fold risk of development of chronic pain. Being exposed to trauma can change how one relates to the environment. This could include hypervigilance, feeling unsafe, and even emotional internalization. Ultimately, at a very basic level, they are not safe. And if one does not feel safe and pain is viewed as a danger signal, this preoccupation around pain and safety can contribute to keeping this signal on. It can lead to this sensitizing of the central nervous system. It is well established that there are high levels of comorbidity between chronic pain conditions and mental health disorders. Mental health disorders such as post-traumatic stress disorder, or PTSD, depression, anxiety, substance use, and personality disorders are somewhat common in the chronic pain population. Screening and treatment of these disorders can help improve pain treatment outcomes, and there are a variety of free screeners out there that providers can use. There is a bidirectional relationship in that pre-existing mood disorders increases one's risk of developing chronic pain, and having chronic pain increases the risk of developing or exacerbating various disorders. So those with comorbid PTSD report higher scores of pain, PTSD symptoms, depression, anxiety, disability, and opioid use than those with only chronic pain or PTSD alone. There are various models that explore how these disorders can perpetuate each other. This can include attentional bias, hypervigilance and hyperarousal, catastrophizing and avoidance, emotional and physiological stress responses. If left untreated, PTSD can undermine chronic pain treatment outcomes. Referring a patient to a trauma specialist is the key to treating PTSD. Depression and anxiety are the most common mental health disorders co-occurring with chronic pain. Depression is associated with poor outcomes, including greater pain intensity, disability, and can interfere with engagement in rehabilitation. We know that depression undermines one's motivation to engage in activities that could help improve their quality of life. And it also contributes to this negative outlook on life or a negative mindset. Anxiety can contribute to excessive worry, rumination, and unhelpful cognitive, emotional, and behavioral responses, all of which can interfere with recovery. There are also free measures or assessments that can look at depression and anxiety. And if you find that these are elevated in your patients, you can refer them to a psychologist that specializes in depression or anxiety and a psychiatrist. Often with the pain psychology treatment, we address depression and anxiety, but what we find is that if they are so depressed that they can't participate in our treatments, then we would want to reach out and get them additional help. Or if they're so anxious that they can't even attend to the sessions, we'd want to reach out and get them connected with someone who specializes in that disorder. It is also important to assess for pre-existing or current substance use disorders, followed by an appropriate referral to a substance abuse specialist or even an addictionologist. Long-term use of various substances to manage pain has been associated with higher levels of pain and poor outcomes. A complete substance use history should be taken prior to prescribing addictive medications, as it can increase the risk of relapse. And finally, personality disorders. So these would include long-term patterns of unhelpful thoughts and behaviors that are inflexible. So they tend to be quite rigid, and they have a negative impact on relationships. So this can be a significant barrier when building a therapeutic relationship, leading to negative interactions. Personality disorders are common in the chronic pain population. So learning to identify them, set appropriate boundaries and expectations is important. And a referral to a psychologist or mental health provider who specializes in dialectical behavioral therapy is recommended. So beyond adverse childhood experiences and mental health disorders, the role of psychological distress also contributes to the onset, maintenance, and exacerbation of chronic pain. Psychological distress is related to thoughts and beliefs. It's not necessarily a distinct mental health disorder. Pain catastrophizing, fear-based thoughts, behaviors, and beliefs mediate the relationship between pain and disability. And these are direct targets of intervention for psychologists, and by addressing it, it will improve outcomes. There are decades of research supporting this. Fear and avoidance behaviors can include fear of pain. So this would be anticipatory fear. So fear of engaging in an activity because it could increase pain. Fear of damage. This person may have conceptualized their pain from an acute pain standpoint. So they're still concerned that, there's ongoing tissue damage in their body that in the moment of an activity could increase that. So this is where pain neuroscience education can be really helpful in letting them know the difference between acute pain and chronic pain. They can have fear of movement or kinesiophobia. They stop engaging in activities that they are fearful of. And then various pain beliefs and pain catastrophizing. Pain catastrophizing is a cognitive, affective pattern of negative thinking. And this includes magnifying negative aspects of the pain. So they have a tendency to magnify the threat of pain. I'm afraid something serious might happen. Also rumination. So this is the inability to disengage from thoughts about pain. I can't stop thinking about how much it hurts. And then feelings of helplessness in coping with pain. There's nothing I can do to reduce the pain. It is one of the most powerful predictors of poor outcomes from pain intensity, disability, surgical and other medical outcomes, medication use, and multidisciplinary treatments. So thinking about catastrophizing, it can increase both acute and chronic pain severity, impact central nervous system pain processing. It actually primes the brain to experience pain. Post-surgical pain outcomes are worse in patients that have high levels of catastrophizing at baseline. Physical disability, mood, pain-related activity and interference, and ultimately poor prognosis. The bottom line is that pain catastrophizing is one of the most robust predictors of negative outcomes. The good news is it's highly treatable. Pain psychology focuses on helping patients identify these unhelpful, catastrophic beliefs that get in the way of their recovery. This is what the fear and avoidance cycle looks like. You can see that there is a psychological cycle and a physical cycle. These two cycles work together in a very unhelpful way. So experiencing pain over time can negatively impact one's mood, leading to higher levels of fear and anxiety or distress, which can further impoverish their mood, leading to depression. And this entire cycle actually increases one's perception of pain. It's like priming their brain to experience pain. Then we have the physical cycle, where if one feels pain and they're afraid of damage or increasing their pain, they start to avoid activities. In the short term, that might not be a problem. The chronic pain is a long-term condition. So what happens over time is there's progressive deconditioning, then pain with even decreased activity, which leads to further avoidance, further deconditioning. And this cycle just continues to feed upon itself. This is where combining pain psychology with physical therapy can be very beneficial, because we help to shift this cycle, this vicious cycle, to more of a virtuous cycle. So I'd like to spend a little bit of time talking about what I do as a pain psychologist. A pain psychologist can wear many different hats depending on what they're focused on. And I also want to talk about the targets of treatment. So what are the areas that we are really focusing on in helping patients get better? So a pain psychologist helps individuals with chronic pain identify these biopsychosocial factors that impact their experience of chronic pain, to learn effective coping strategies, and to re-engage fully in their lives. When I say we help patients get better, what I mean is we help people re-engage fully in their lives. And so we focus on things that patients have control over. So this would include pain neuroscience education, active coping skills, and engagement in valued life activities. Therapy is collaborative and encourages a person with pain to take an active role in their own recovery. We provide assessment, treatment, and consultation. So for example, I work within a multidisciplinary and an interdisciplinary team, providing guidance to my medical and physical therapy colleagues. I can comment on the psychological appropriateness of patients for various invasive or interventional treatments, medication adherence, and treatment planning, including looking at risk factors around destabilization or potential for misuse or abuse of medications. During a pain psychology assessment, I explore the patient's understanding, beliefs around their pain and behaviors, medication use, their expectations for treatment, risk and protective factors, psychiatric history, and current life stressors. I'm a licensed psychologist who attended an APA accredited postdoctoral fellowship that specialized in chronic pain. And I really focus on helping patients, build their toolkit. So strategies that can help them manage their pain, encourage healthy lifestyle choices, and various stress management tools. Therapy is recommended in conjunction with medical treatments and physical therapy treatments, not after all medical interventions have failed. This is something that we really want medical providers to understand, that it's not you go to pain psychology after everything has failed. You want to think of this as early intervention. You want to bring us on board early into the treatment planning, because it'll make a big difference in the trajectory of the patient's outcome. So we provide education for the patient on this dynamic interaction between pain and mood. We help them learn strategies to reduce emotional distress, and really focusing on these adaptive coping skills to help them improve their participation in life. This is a slide that I would use with patients that I work with, and it really just helps to highlight the trajectory of their experience of pain. So in the beginning, people are very busy with their lives, right? Busy shopping, running errands, self-care, maybe working and going to school, spending time with friends and family and hobbies and leisure. Life is full. Life is very full, and they're just getting through their day, doing the things that they have to do and the things that they want to do. What happens at the onset of pain is that pain is part of the picture, but it hasn't completely hijacked their life. It hasn't taken over all aspects. But this changes over time. With unmanaged pain, pain becomes the driving force in their life. I've had patients say, it's all I can think about from the minute I wake up to the moment I go to sleep is, how am I going to get rid of my pain? How am I going to manage my pain? And everything in their life, from leisure to fun to work to volunteer, time with family, is dictated by their pain. Patients no longer feel as though they're in the driver's seat. They feel like pain is running the show, and they're just kind of being pushed around and dragged around. So the goal is to help them re-engage in these activities that are important to them. Now, pain might still be a part of the picture. For many patients, chronic pain is a condition that is persistent over time. But the goal is to help them feel more in control, give them skills that they can use so that they can re-engage in these activities that are important to them, so that pain is no longer driving the car. They're driving the car. And on a good day, maybe pain is in the back seat. On a really good day, maybe pain is in the trunk. So these are the various treatment targets, some of which I've already mentioned. Pain neuroscience education, catastrophizing and fear, thoughts and beliefs, behaviors, and self-management. The ultimate goal is self-management. I want to give my patients the tools so that they don't need me. They don't need to come see me anymore. They know the skills, they know how to use them. They're using them on a day-to-day basis in a preventative way. They're self-managing their pain with bolstered self-efficacy, that belief that they can manage what's happening in their lives with the tools that they have. The gate control theory of pain and the neuromatrix of pain are two effective teaching tools that we use in pain psychology. I would consider this pain neuroscience education. So the gate control theory that was developed by Melzack and Wall is a theoretical conceptualization of how we experience what we experience. So as I mentioned, in the beginning of the presentation, that we receive signals from the periphery that come up through the spinal cord into the brain. The brain decides whether it's pain or not. And so with the gate control theory of pain, we would focus on these factors that modulate the pain experience. So things that would close the gate on pain at the level of the spinal cord. These could be thoughts and beliefs. These could be behaviors. And they could be things like exercise. And so it's helpful to explore what are some of the more active coping strategies that patients are using to help to close the gate which would decrease the experience of pain. This is a slide that I showed a little earlier on. So after I do an evaluation, I sit down with patients and I look at this slide. And then we go over the fact that, again, pain is the brain's best guesstimate of what's going on in the body and whether it is dangerous or not. So my role would be to help identify the factors for a particular patient that might be contributing to their experience of pain. So we'll talk about diet and sleep. We know that disrupted sleep can make them more sensitive to pain the next day. Longitudinal data also suggests that insomnia at baseline can contribute to people experiencing chronic widespread pain later on in life. We look at their beliefs, their emotions, their environment, their memories, their exercise plan, stress, support, their overall health profile. And what I would like to highlight in this slide for you today is on the bottom right, which is medical advice. There's a lot of support around the notion words that hurt and words that heal. And this is in relation to what providers tell patients about what's going on in their body. So I'll have patients that come in and say, my doctor told me that my knees are bone on bone, or I've been told I should never lift more than 10 pounds, or bend forward, or lift my arms above my head, or that my MRI shows that my spine looks like an 80-year-old spine. Patients remember these things that medical providers and other health providers tell them, and it becomes part of their experience of pain. If I believe that when I bend forward, I'm going to rupture my disc, I'm never going to bend forward. And so it's really important to make sure that a statement that you might think is benign, that you don't think has any fear, may have a strong impact on a patient. And so making sure that we are describing what's happening in their body in a way that is accurate, of course, but also doesn't add to the fear that they have. So we want to use words that heal versus words that harm. And I believe that Lorimer Moseley has written quite a bit about this. So here's a metaphor that I use to explain the sensitivity of the nervous system over time. So chronic pain is not an accurate indicator of tissue damage, but it's rather your brain's best guesstimate as to how much danger your body is in and how much pain is required to protect it. We know that just because something hurts doesn't necessarily mean your body is being harmed in that moment. So when things are working correctly in the nervous system, it would be like the fire alarm going off when a house is burning down. It's an accurate indicator of something wrong is happening and I need to do something. I need to get out of the house. This would be what is happening with an acute pain injury. If I break my ankle, the pain is warning me that there's something dangerous going on in my body that I need to deal with. So let's look at the other side. What happens when the fire alarm keeps going off when we have burnt toast? The alarm is real, it's going off, but it's not giving us accurate information around what is happening in the home, because burnt toast, although it's unfortunate, it is not dangerous. I'll explain to patients, this is what happens with chronic pain over time, is that your fire alarm, your brain, is going off, giving you signals of pain when you've burnt toast. There's no longer danger in that moment in regards to the tissues. And so it's this faulty alarm, this oversensitized alarm system that has become part of the problem. So what we want to do is we want to try to focus on strategies that can help reset this harm alarm system. This is really where neuroplasticity comes in, changing how we think, developing different neural pathways, changing how we behave, developing neural pathways. And this is an easy way to explain this in a way that is validating to the patient. It's not that the alarm that's going off isn't real, it's just got inaccurate information. So I talked about the vicious cycle, the fear avoidance cycle of chronic pain. This is the virtuous cycle. So this is what we're trying to turn that downward spiral into an upward spiral. Coping with pain. We're instilling hope. Hope that things can be different. As you behave differently, you get a different outcome. Instilling positive emotions and focusing on self-efficacy, that belief that they have the ability to do what they need to do and that they have skills to manage whatever comes up. Focusing on self-management, giving them the tools that they can use to manage what's happening for them. And then from the physical side, activity engagement. So getting them back involved in activities, whether this is through the help of physical therapy, graded exposure, time-based activity pacing, but ways that help the person with pain feel in control, confident to get moving again. Building strength and endurance, which can help to decrease sensitivity. And then again, this is all about changing the way the brain is responding to those signals. We do this through various psychological treatments. Many of these I'm sure you have already heard of. Cognitive behavioral therapy, that's the most widely studied psychological treatment that we have for chronic pain. It's been around the longest. Acceptance and mindfulness-based therapies, so some of these third wave therapies that have been found to be efficacious for the treatment of chronic pain. Biofeedback. And also, I wanted to provide you with some self-help resources and then information on referrals. So as I mentioned, cognitive behavioral therapy has been the most widely studied treatment for chronic pain. And it really focuses on identifying unhelpful or inaccurate cognitions and behaviors. We identify them, help patients address them. So with cognitive behavioral therapy, the idea is that what you do, so your behavior, has an impact on your thoughts and your feelings. How you feel affects your behaviors and your thoughts. How you think, so your cognitions, can affect how you feel and how you behave. And all of these can also have an impact on one's physiological response. So CBT is a structured, time-limited, collaborative, present-focused approach that aims to help patients actively engage in coping. And so we have a list of what we call unhelpful thinking styles, from black and white thinking to overgeneralization to mind reading. And in the chronic pain world, we spend a lot of time focusing on pain catastrophizing. That's a big target of treatments, and fear avoidance. So catastrophizing and fear are something that we can address with cognitive behavioral therapy and help them change not only how they think, but how they behave and how that affects their whole physiological system. Addressing these thoughts can impact perceived pain, depression, and ultimately improve outcomes. A helpful cognitive therapy strategy is called cognitive restructuring. And we can do this using what's called the 3 C's. So in CBT, the idea is to help people recognize that, thoughts are automatic. They tend to be negative in general and often unhelpful. And a lot of the time, they're not even in our conscious awareness. So what we want to do is we want to help patients catch an unhelpful thought. So for example, if someone spends the day cleaning their garage and then their pain spikes. They might have the thought, I can't do anything anymore. Okay, that would be a thought. I will tell you that catching your thoughts is pretty challenging. So what we do is we ask people to tune into their emotions. So when you had the pain flare, were you feeling sad or anxious or angry? And if this person said, well, I was feeling sad, my next question would be, well, what were you thinking at that time that led you to feel sad? That's the catch it. Oh, I was thinking, gosh, I'm never going to be able to do anything anymore. And so once we catch the thought, we would then check it. And we do this through a very structured way. So I would ask the person to reflect on how accurate this thought is. And when I say accurate, I mean factual evidence that would support or refute that thought. So you can even pretend that you are in court and there's an attorney that's asking you, what factual evidence do you have that would support you can't do anything anymore? And how useful is the thought? So for example, after cleaning the garage and having a pain flare, having the thought, I can't do anything anymore. Well, it's not accurate because you just cleaned the garage. So that would be one way to look at factual evidence that that thought is not accurate. And then, is it helpful? No, it's not helpful to think I can't do anything anymore. And then the next step would be to change that thought into something that's more accurate or helpful. So something that would be more accurate would be, I spent the day cleaning the garage and I did end up with a pain flare. Next time, I could use my time-based activity pacing so that I make sure I take appropriate breaks and use my diaphragmatic breathing to help calm my nervous system. That would be a more helpful thought to have. The idea is that by changing your thoughts, it does change how intense your negative emotions are. So that sadness maybe goes from a 90% sad to maybe feeling 40% sad. And it also allows you to look at your behaviors, like what can you do next? When we're caught in these negative thoughts, they often hijack us and we feel like we don't have any options as to what we can do next. So by challenging your thoughts, it actually introduces choice into the equation. We also provide self-regulation training, so diaphragmatic breathing, progressive muscle relaxation, body scans, meditations, guided imagery. There's so many different types of self-regulation skills, but the idea is to teach these skills to patients experiencing pain so that they can practice them on a regular basis. So they have a skill that they can use anytime they need to pump the brakes on their nervous system. I also mentioned time-based activity pacing. This is an incredibly powerful skill. Most people living with pain use their pain to gauge how long they're going to do something and how much they're going to do, if they're going to do it. So that puts pain in the driver's seat, which of course is not helpful. So with time-based activity pacing, they focus on using time, distance, or repetition to engage in activity. So let's say someone wants to get back to walking, but they know if they walk for 20 minutes, they end up in this boom and bust cycle where they can do it, but then they have a pain flare for hours or days. Maybe we would start a walking program for 10 minutes. They'd set their timer, they'd walk for 10 minutes, and then they would do 10 minutes of some sort of self-regulation, whether it's stretching with diaphragmatic breathing or maybe a body scan, something that calms their system down. And then the next week, they would increase their time in the activity by 10%. And then the next week, 10%, and the next week, 10%. So the idea is that you're now associating walking with being able to do it versus pairing walking with pain. And they are kind of flying under the radar of their pain, putting them back in control of what they're going to do and experiencing some success around activities. So it's a way of breaking up activities so that they're not trying to power through and then suffer later, because that doesn't work. It's giving them a different strategy. I like to refer to this as working smarter, not harder. And by doing this over time, people's productivity actually increases because they're not spending so much downtime trying to recover from a pain flare. We also target sleep. We know that unmedicated sleep is the best for the brain, and that cognitive behavioral therapy is the best treatment option for sleep. So we'll teach sleep hygiene, and if patients have insomnia, then they would undergo cognitive behavioral therapy for insomnia. We have them re-engage in pleasant activities. This is really important because so many of the fun activities just get crossed off the list. And so for patients who are struggling with low mood, this behavioral activation is really important. So getting them re-engaged in things that they find pleasurable. Communication training. So we want to help them educate the people in their lives on what they're doing and why they're doing it so that they can support their adaptive coping strategies and reduce some of the passive coping strategies, and also reduce some of the solicitous behaviors that can happen with family members who want to be helpful, but that solicitous behavior is actually not helpful. And then, of course, a coping prevention plan so that if they have a pain flare, they have a concrete plan of what they're going to do, active coping strategies they're going to use to get through that pain flare versus reverting back to their passive coping strategies that will just prolong that pain flare. And then with everything that we teach them, we use goal setting so that they know exactly how they're going to implement these strategies into their day. I talked about self-regulation, and this is where we really want to help patients understand that we are trying to engage the parasympathetic nervous system, this relaxation response, because we want it to counter this sympathetic nervous system fight or flight response. So the treatments that I mentioned, like diaphragmatic breathing and the body scans, can be really helpful. These skills are used daily, focusing on prevention, not reaction. They can also help to foster this mind-body awareness, optimizing their daily function. So this is the first skill that I'll teach patients, really understanding why we would do this self-regulation, how it works in the body, how it helps with pain, and that it's about doing it every day, making it a part of your day. Because if you experience pain daily, then doing, pumping the brakes daily on the nervous system is also helpful. Mindfulness and acceptance-based therapies are also empirically validated treatments for chronic pain. Meta-analysis have demonstrated efficacy in addressing depression, disability, quality of life, anxiety, and pain interference. And they have been shown to be comparable to CBT in addressing pain. So acceptance and commitment therapy, which is on the left, also called ACT, works to help patients identify their values and then engaging in behaviors in line with those values daily. So that's a committed action. So first it's, doing what matters on a daily basis. Also to mindfully diffuse or unhook from unhelpful thoughts, feelings, memories, and sensations. So this would be being present, making contact with the present moment. That's a mindfulness piece. Diffusion would be unhooking from these thoughts that push us around or hijack us. So this is really about opening up to your experience so you're no longer fighting with it, trying to push it away, ignore it, or deny it. At the heart of ACT is psychological flexibility and acceptance. Acceptance could also be described as willingness to experience what's happening in the moment. Pain acceptance has been found to contribute to physical and psychosocial adjustment, positive patient adjustment, and demonstrate improvements in pain-related functioning, mental health-related quality of life, self-efficacy, depression and anxiety, and psychological inflexibility in the chronic pain population. Mindfulness is essentially a way of being, characterized as conscious present moment awareness with a stance of remaining curious, open, and non-judgmental. So there are formal and informal ways to be mindful. It's simply observing rather than avoiding, resisting, or struggling with our internal experience. This stance can help promote acceptance and willingness to sit with whatever is happening in that moment versus getting emotionally pushed around by it. This paying attention on purpose can help reduce the interplay between what the brain tells us and how we interact with those messages. It can help with reduced suffering. Mindfulness-based stress reduction was created by Jon Kabat-Zinn, and it is a treatment for chronic pain. It's an 8-week treatment that is offered throughout the world. Biofeedback focuses on awareness, control, and generalization. So we know that living with pain can activate the nervous system. So it can activate the sympathetic nervous system, leading to an increase in heart rate, sweating, muscle contraction, that bracing and guarding that can happen with chronic pain. And biofeedback is a wonderful strategy or therapy that we can use to help patients recognize what's happening in the body, what does that mean, teach them ways to control it, and then generalize their skills into the day-to-day life. So the first stage, the patient gains awareness of his or her problematic physical response. So they can identify how their bodies respond to a variety of stressors. You know, do you lift your shoulders up and tense your muscles? Do you have a tendency to shift into rapid chest breathing? And this can determine which type of modality we want to use with them. So we hook them up to these various sensors to measure the breathing and the heart rate, sweat gland activity, muscle contraction. And then the first step is we just put it up on the screen. So it's feeding back that information in real time so the patient can see what's happening. And then we educate them on what it means. Are they having a stress versus relaxation response? So it's that awareness piece. And then we teach them control. So they can learn to control their physiological responses by changing how they breathe, changing how they think. And then they see how they can actually shift into that relaxation response by changing what they're doing or thinking. And then the ultimate goal is to help them generalize those skills into their day-to-day life. They learn this through trial and error, so they can identify their triggers that can alert them to implement these self-regulation strategies, so that at the conclusion of treatment, patients no longer need to be hooked up to the machines because they've internalized their awareness and they have the control and they can generalize it into their day-to-day life. I like to call this as psychophysiological therapy because it really helps patients understand this mind-body connection, and it gives them that information in real time of what's happening so they can start to become more aware of how they can control these various responses. So if you're thinking about adding a pain psychologist into the treatment with your patients, I would encourage you to look at how these psychosocial factors can really impact medical outcomes. We know that multidisciplinary treatment is far more effective than monotherapy. There's good research outcomes with the various treatments that I discussed, the CBT, the mindfulness and acceptance-based therapies, and biofeedback. Pain psychologists can also help the medical providers make appropriate treatment selections. We can assist with medication optimization, adherence, and reduction. So the skills that I shared with you today are helpful if you have a patient who is interested in undergoing an opioid taper. And this combination of adding pain psychology into the treatment plan can actually help improve medical and functional outcomes. So who should you send to see pain psychology? If you have a patient that their pain is lasting longer than 3 to 6 months and that they're having minimal functional improvement. So you've been working with them and things are not getting better. if they have a history of adverse childhood experiences or trauma, if their pain started in the context of various life stressors, we know that that can have an impact on the trajectory of pain. If you find that their mood is impacted, depression, anxiety, PTSD, if they have fear of pain, fear of damage, fear of movement, or you're noticing fear avoidance behaviors, catastrophic thoughts, so that rumination, magnification, and helplessness around their pain, if they're having difficulties with adhering to the medication plan, or they have an interest in mind-body therapies. I mean, I will tell you that most of the patients that I see when they come in to meet me for the first time, they're not necessarily interested in mind-body therapies because they've never heard of pain psychology, unfortunately. We are trying to change that. But after the evaluation, after I've gathered all the information and put it together for them at the end, they're appreciative and they're interested in understanding how they can take back control of their lives and re-engage in activities that are meaningful to them. It's important to acknowledge that sending them to a pain psychologist is not because you think they're making up their pain or that it's all in their head. It's that you understand that the experience of pain is the result of the brain's best guesstimate of what's going on in the body, and that there are so many contributors to that guesstimate, and that pain psychology can help with improving their outcomes across the board. I wanted to give you some self-management resources that you could use with your patients. So the first is tamethebeast.org. This is Lorimer Moseley's website, and it has real stories of recovery and podcasts. It's helpful for both patients and providers. There's a wealth of knowledge on this website. The Curable app is a combination of pain neuroscience education, brain retraining, expressive writing, and mindfulness meditation. I believe it's one of the most helpful apps out there for helping patients really understand what chronic pain is and various treatments that can be helpful. If patients are unable to purchase the Curable app, they put out a Like Mind, Like Body podcast that is free. Pain education books. The Pain Survival Guide is a cognitive behavioral therapy book, self-help book for chronic pain patients. Living Beyond Your Pain is a acceptance and commitment therapy self-help book. Explain Pain is a pain neuroscience education book. And Full Catastrophe Living by Jon Kabat-Zinn, who's also the founder of Mindfulness-Based Stress Reduction, is a mindfulness book that can be helpful as well. These are some resources that I also think are helpful. Understanding Pain and What to Do About It in Less Than 5 Minutes, and Understanding Pain, Brain Man Stops His Opioids, are less than 5-minute videos, whiteboard animations that are really helpful. We also have a YouTube channel where we have various pain specialists provide talks on chronic pain. On tamethebeast.org, It's Time to Rethink Persistent Pain is a wonderful tool for patients as well. And then Lorimer Moseley also has a great TED Talk called Why Things Hurt. Thank you for joining me today. I am passionate about helping medical providers understand the role of pain psychology. And I hope that if you have any questions or want to share feedback with me, that you reach out to me. And again, I so appreciate you joining my talk today. And also, I want to thank you for all the work that you do with the people out there that are living with chronic pain.